Thank you very much for the kind introduction. And can I have the first slide, or do I have to do something here to activate? This talk is on osteochondral defect, but the ones that think that it's on cartilage, it is mainly the talk will be on the bone. The title of the talk is The Rationale for Diagnosis and Treatment for Osteochondral Defect. And if we look at osteochondral defect, we're talking about chronic lesions, chronic localized lesions. And they can be cystic lesions, there can be loose fragments, there can be a variety of manifestations of these defects. And the main question is, why do we treat a patient with a localized osteochondral defect? And basically there's two reasons. The first is to resolve the symptoms of the patient, and the second is to prevent arthrosis. But can we prevent arthrosis? Because we know that the natural history of this osteochondral defect is benign. If you look at it from patients that come with ankle arthrosis, it seldom started with an osteochondral defect. So we have to be humble, and I don't think that we can say, and from the literature, we cannot say that with our treatment we prevent arthrosis. So the reason to treat is to resolve the symptoms. So what's the main symptom? The main symptom is pain. The patient comes with pain. So if we know the cause of the pain, we can treat the patient. Patient comes with pain, we want to treat the pain. Before I go to the anatomy, first, the difference between the ankle joint and other joints in the body. The ankle joint is the most congruent joint in the body. And the interesting thing is that the more congruent the joint, the thinner the cartilage. The ankle is the most congruent joint with the thinnest cartilage. The knee is the cartilage that's the least congruent and has the thickest cartilage. In humans, the thickness of the cartilage in the ankle is 1.2 millimeter. In the knee, it's 2.2. So then look at the anatomy. We all know the anatomy of the cartilage. The cartilage, it's chondrocytes, proteoglycans, collagen fibers, but 75% of the cartilage is water. We all walk on water. And the water is supported by the subchondral bone plate, and in the subchondral bone plate are the nerves. As we know, there is no nerves in the cartilage, but there are nerves in the subchondral bone. So if we then go back to the question, what causes the pain in patients with osteochondral defect? Is it the interarticular pressure? In the ankle, that's not the case. Is it the synovium, the capsule? In the knee, that's part of the problem in arthritic patients, in localized osteochondral defect patients. But in the ankle, it's not the case. These patients come with deep ankle pain, and you cannot, by palpating the synovium, reproduce the pain that the patient experiences during his activity. He might have some secondary synovitic pain, but the pain comes from deep inside the joint, the pain comes from the bone. So if we then have a defect like this, how can the nerves in the bone be stimulated with a defect in the cartilage? They can only be reached if there is insufficiency of the subchondral bone plate, if there's an opening between the joint and the subchondral bone. And it needs force, and the force on the ankle is quite high. On normal walking, 4 times body weight, this is almost 3,000 Newton, go onto the talar surface. And we know that not all goes through the talar surface. Part of the forces goes through the lateral malleolus, part through the medial malleolus, but it's about 2,400 Newton on every step on the tibio-talar contact area, which is 4.4 square centimeters. There is this load that is distributed on this talar contact area. That is 505 Newton per square centimeter. So if we then look at an osteochondral defect of typically 1 centimeter in size, it's 10% of the weight-bearing cartilage. So if we treat this, if we remove it, is this 90% that it's left, is that enough to bear the load of the patient? And we know from the natural history that that's the case. But do we know it from biomechanical investigations? And we know from investigations in fractures, ankle fractures. We know from Ramsey and Hamilton in 1976, and recently in Foot and Ankle International 2006, the same measurements were found. If you have a displacement in a fracture of 2 millimeter, then there is an increase in load that is too much. And so 2 millimeter of displacement is an indication for fixation, because only 40% of the weight-bearing area is kept. However, if you have 1 millimeter displacement, you have 40% less contact area, so 60% contact area remains, and that's not an indication for surgery. So probably this 60% is the margin on which we still can expect normal weight bearing without degenerative changes. So if we then look at the osteogondral defect, then with this 1 centimeter, it should be okay looking at these experiments. And even a defect of 1.5 centimeter is still within, let's say, the safety margin of removing the fragments and leaving it empty. So what happens on loading? If we look first at the knee on the right side, the knee with the 2.2 millimeter cartilage, we know on cyclic loading that the cartilage compresses and the water, 75% is water, the water flows in the cartilage, flows into the joint space, and in unloading, the water goes back into the cartilage. On cyclic loading, the joint compresses 16%, on static loading even 45%. That means if you stand all day, you're shorter at the end of the day when you go to bed than when you raise in the morning. What happens in the ankle? If you compress, the water compresses. It cannot go into the joint space because of the high congruency, and that's why the cartilage compresses less than in an incongruent joint like the knee joint. Then we go to the pathologic situation. In the pathologic situation, we have softening of the cartilage. There is dead chondrocytes in their lacunae, less proteoglycan content, more water content. And then if you have an opening in the subchondral bone, then on every step, the water is compressed in the subchondral bone, leading to the water white on T2 that we see on the MRI. And if this happens over time, over months, over years, it will lead to cystic lesions due to the pressure of the water dissolving the bone. And since we have nerve endings in the bone, this pressure in the subchondral bone will be detected by the nerve endings, and this will be the cause of the pain of the patient. We know that this pressure on walking is capable of dissolving the bone by the experiments that were done in our department, Van der Vis, together with Aspenberg, in which repetitive load was placed on the cortex of a rabbit, and then we saw osteolysis in all these cases. So pressure is important, and this is an important patient. 15 years ago, this was an orthopedic surgeon, he still is. He retired this year. In my department, he had this fracture. He had this fracture, simple fracture, which was treated with 2 screws, but he had a valgus alignment and probably a crack in the cartilage here, because in 9 months, he developed this large cystic lesion on the lateral side, which you see here on the CT scan. And he asked me, can you not just perform a corrective osteotomy, a sliding calcaneal osteotomy? And that's what I did. I just did a calcaneal osteotomy, sliding the calcaneus to the medial side. I didn't do anything on the cyst, just unloading the lateral side. It was 15 years ago, he retired this year, and he is still very happy with the result of this operation. He didn't have any complaints since then. So my message is, address the subchondral bone if you have an osteogondral defect. And when you adequately address the subchondral bone and the overlying cartilage, you have 80 to 85% success. We know that from the systematic review that we performed and published in the Case Star Journal 2 years ago. If that's the case for the treatment, it's also true for the diagnosis. So I'm not interested in the cartilage if I have an osteochondral defect. I'm interested in the bone, because the bone gives the symptoms, the bone gives the pain, I want to treat the bone. If you make a CT scan, you have to do a reconstruction in coronal and the sagittal plane, not just for your diagnosis. And we've been publishing the results of MRI versus CT scan. We published in the British Journal of Bone and Joint Surgery. MRI and CT scan are as good for the diagnosis, but for the preoperative planning, I prefer the CT scan because it tells me what I have to do, which cyst I have to open, which fragments I have to remove. Then look at it from the therapy. This is the outcome of the meta-analysis that we performed. We published in 2000, Hans Toll, one of my co-workers, we published the meta-analysis, and here you see the result of that meta-analysis, and here the 2010 in the Case Study Journal. And we see that excision-curettage bone marrow stimulation has an 85% good, excellent result. And the interesting thing is that the other treatments that treat the bone, like oats, 88%, retrograde drilling and fixation, the treatments that address the bone, they have the highest percentage of good, excellent result. But retrograde drilling is for large cystic lesions and fixations for lesions more than 50 millimeters. So let's look at the excision-curettage bone marrow stimulation and some of the other treatments for a moment. The treatment of the osteochondral defect in the ankle by arthroscopy, we do that by bringing the ankle in plantar flexion, like this. If you plantar flex, 95% of these defects come into the anterior working area, and you can debride and you can stimulate the bone marrow. If you're uncertain, and we recently published this, we make a CT scan in plantar flexion. And here the defect seems to be quite posterior, but if you make a CT scan in plantar flexion, you can, like this, then you can detect how much of the osteochondral defect will be in front of the distal tibia. We measured that in this, what we published recently, and it's very accurate, what you measure on the CT scan and what you measure during the surgery. This is the distal tibia, this is the anterior part of the defect, and there was a high correlation between the intraoperative and the CT scan. So the CT scan tells you exactly what you can expect during your surgery. Then on the fixation, this is just an example, professional basketball player with a large defect. And the defect is almost 50% of the talus. It's a necrotic talar ridge. So then you have a problem because it's too big for an oats, it is too big for debridement and bone marrow stimulation. And so probably the best, when there have not been an operation before, is to refix. And refix, it means to treat the bone. This is just to show you the technique. This is on the medial side, but on the lateral side you can do the same. This is the defect. You just cut the cartilage, you open it, debride and bone marrow stimulation underneath, fill it in with cancellous bone, and place it back with a screw. So open it and close it, and that's what we did. And here you see the screw in place, here the situation, and here 1 year later, the patient telling me, or the doctor of the patient telling me that he's in good health, in full competition if I wanted to remove the screw. Of course I wanted, but he had to play another match, and it's now 3 years ago. The screw is still in, and he is still in full competition. So it's important, the fixation, the best graft is the hyaline cartilage that is in the patient. So if you have a defect like this, always think of fixation of a defect. Another new device that you can consider, I consider it for secondary lesions. Again, a big defect in the subchondral bone. For me, it doesn't matter so much with what you fill it in. You can fill it with metal. For example, this metal device, as long as the cartilage of the opposite side is not compressed. And then the last method that I wanted to show you, the patient, the orthopedic surgeon in my department 15 years ago, inspired me to go more and more to do these calcaneal osteotomies. Orthopedics is biomechanics, is alignment, realignment. So always consider realignment. And of course, this is a clear varus malalignment, and normally we would have done arthrodesis, maybe a prosthesis. But more and more I do these calcaneal osteotomies, and here you see the preoperative, and here you see what happens in an osteotomy. You shift the load to the lateral side. This has taken maybe 20, 30 years before it became symptomatic, so you buy maybe another 10 or 15 years by doing the osteotomy. Here another example, a varus, a bad varus alignment, here after the osteotomy. The hemicaps, I did 44. I have 2 failures. This is one of the failures, and you see what happens. This is just after the operation. Half a year later, you see there is a big cyst on the opposite side because I put it in too proud. I just did the osteotomy, and you see that the cyst has disappeared. So the patient is still happy. I did the 2 patients that I put it in too proud. So this is a very powerful tool to consider when you have a failed primary treatment of your osteochondral defect. And this step plate is a good and new plate to treat it by. So my conclusion, my treatment algorithm for osteochondral defect of the talar dome: asymptomatic lesions, conservative with a cast, period of 3 weeks. Symptomatic lesions with a diameter up till 15 millimeter, excision curettage bone marrow stimulation. Larger lesions, fixation or an oat, but you can always consider the excision curettage bone marrow stimulation. The percentage goes down of good, excellent result, but you can always consider it. Large cystic lesions, retrograde drilling, again, consider the excision curettage bone marrow stimulation, and only for secondary lesions, I will go for an oat, for a Goldner-side graft, a hemicap, or an osteotomy. I showed you several techniques. This site, it's free. It shows you all the operative techniques, arthroscopic as well as open techniques. It will show it in pictures. It will show it in video. So if you want to learn more about these procedures, you're very happy to visit the site. Thank you very much.
Thank you, Nick van Dijk, for this very clear presentation. Is it now any question?